Okay, so we're just going to go through the assessment. First, I'm going to start with a little bit of the shoulder assessment that I talked about in terms of loading up the supraspinatus muscle and the infraspinatus muscle and getting positive signs on those. So there was 3 tests in particular that led me to the fact that we're having a little bit of an irritable supraspinatus. The first one is when I'm taking it through passive range of movement, and we're looking for that end range pain where you get to that very end, and they talk about sort of almost a mole catching pain at the back right onto that supraspinatus attachment. Our muscle resistive test that we use will obviously be muscle resistive abduction, so just pushing up against me and then getting a positive sign at the attachment usually. Relax. Internally rotate and push up against me. Positive sign for that as well. And then finally we may also have a positive Hawkins and Kennedy, so just pushing up against me and having another positive sign there. So they're sort of the 3 tests that I use specifically for supraspinatus. And look, there's a whole range of other ones as well. We can obviously assess in different parts of the range of movement as well, but I'd like to see at least 3 positive signs in testing supraspinatus to really pinpoint the fact that it is supraspinatus, that it is aggravated. Now, having said that, and because we're talking about lateral elbow pain, we can't discount what happens here in the neck as well. So therefore, we've also got to look at the structures and the muscles that also refer to the elbow. First in a long line of, I suppose, muscles that refer there, and I see probably more so, is our Scalenes muscles. So it's important that we're always trying to clear the Scalenes muscles in or out, considering that this person was also an electrician, so there was a lot of lifting and also doing a lot of above head drilling and so forth, and then having the head in obviously a lot of positions of extension. So in terms of assessing Scalenes, also I tend to always look at the picture of what's happening on the lateral flexion. Is there a tight soreness or a tight stretch or a sore stretch? So just taking it down into lateral flexion and then just pushing up against me, cam, and relax. And obviously having a positive sign for soreness through that area. Now that's not always the case. You're not always going to elicit a sign with Scalenes. Scalenes, as we know, can have just latent trigger points that can create a whole range of problems. And Scalenes being the muscle that also mimics a lot of nerve pain as well. The trigger points for Scalenes mimic nerve pain themselves. They're exquisite trigger points, aren't they? I mean, if you press on them yourselves, they're unlike any other trigger point. And that's basically because we have got the nerves in and around that area. We can do the Scalenes cramp test. I don't know if any of you are familiar with this test. The idea is that we take the neck into rotation and then try and drop the neck in behind the clavicle. So you're dropping in like so forth and then holding it there for about 5 minutes, for about 30 seconds. And usually that'll elicit a certain amount of pain and discomfort in that area. And relax, okay? So that's the Scalenes cramp test. So Scalenes were certainly tight in this particular client. We had the supraspinatus path going on as well. And also we're looking at any, as I said, glenohumeral problems. We're also going to be looking at what's happening with the pec minor muscle as well and looking at range of movement for pec minor. Now, looking at range of movement for pec minor, I use a palpatory sort of test. It's a test that I've been using for quite a while, and it lets me know essentially the tensional range of movement for pec minor. So the trick is to get onto the coracoid process, which is where the pec minor attaches. Put your finger right on it, okay, and then bring the shoulder into flexion so that it's disengaged, okay, it's nice and relaxed, and then taking it through into extension until it starts to pull onto that coracoid process, and that will indicate to me how much tension is on that pec minor. So for someone, in terms of tension, I'm obviously looking from one side to the other, but in terms of someone being tight, then anything that engages at that neutral point here, so if we're getting tightness here, that would indicate that pec minor is tight for me. If I was back here and it was engaging, then I know that they've got a fairly good tensional range of movement on that pec minor. because pec minor is an internal rotator, we'll also have to clear out our subscapularis as well, okay? And looking for evidence for subscapularis, let's look at internal rotation of the shoulder. So we're always looking at what happens to the shoulder when they internally rotate, okay? So they're putting their hand behind their back. What happens to this glenohumeral joint? Obviously it internally rotates, but how much does it internally rotate? So if you see, I'm probably a fairly good candidate from the point of view that I've got some ongoing rotator cuff issues, as you'd imagine, 19 years of this type of work. This right one's obviously the worst, it's the symptomatic one, so as I internally rotate and put my hand behind my shoulder, you'll find that the rotation is quite extensive, and it drops forward and down, as opposed to this one that sits back nicely. Okay, so that's the sort of things that we're looking for. We can also do the lift-off test to see if there's any restriction and pain in that subscapularis as well. Can you lift your hand off your back? Any pain with that? Cam? No. Okay, now push up against my hands and I can do it resisted as well. Okay, so if they've got a nice tight subscapularis, they'll probably really struggle with that. Okay, so we've got scalenes and we've got the glenohumeral, so we need to clear these areas out before we even get to the elbow, all right? So we're obviously incorporating the structures above. Now, I can do some neural testing, some upper limb neurodynamic testing, or upper limb tension test if you like, and I did do that on this particular chap, and I really didn't see that much of a change that would include looking at any peripheral nerve entrapment, so which was good, but still had to clear it out in the process. All right, so what I want to do first is I want to go through the treatment of scalenes, and then we'll go through the treatment of pec minor, subscap, and then we'll work our way down through the triceps, Anconeus, flexors, extensors, and supinator. You happy with that, Cameron? I'm using the same products for all of these case studies, so it's just a little bit of MyoWax and MyoLube, and we've also got some massage cream there. How are we looking there? And you can see that all right? Everyone see that okay? All right, so scalenes. We all enjoy working scalenes. Someone asked me about arteries, the last case study I did. So if you're feeling anything pulsating underneath your fingers, then just get off it. So if you're in the vicinity of the carotid artery, but usually if you know your landmarks and you know your anatomy well, you shouldn't have any problems there. Our landmark for scalenes is this muscle here. This is our SCM. So we need to be usually just directly underneath the SCM to get that scalenes medius. And then to get the anterior, we need to push SCM out of the way and then lock down. Okay, so it's just slightly a little bit more anterior. So we roll back, we're on medius, and then obviously the posterior is right at the back here, which usually elicits that really exquisite pain as well. So we're going to clear out this scalenes. I'm going to start with the anterior first, and then I'll do the medius and then a little bit of the posterior. But even before I do that, sometimes, Cameron's actually not too bad, but I remember treating this, the electrician, this particular case study, his SCM was really, really tight and restricted. So access to scalenes anterior was limited because of the SCM hypertonicity. So if that's being the case, we can just clear out that SCM just by doing a lot of longitudinal glides. So picking up the SCM itself and just dragging it up towards the mastoid and just bring in a little bit of rotation so you get access to the whole muscle there. You can give me any feedback that you want. Cameron?
That's all right.
No, we're not strangling him. His trachea is there. And there's certainly no longitudinal gliding to the carotid artery either, or effleurage. Is that pressure too much,
No,
Cam?
fine.
You sure?
Yeah.
So you can imagine I'm engaging this tissue quite vigorously, and you're not always going to get this sort of reaction with most of your clients, especially those that come in with any sensitivity around this area will probably struggle with this type of. Now I'm going to just lift Scalenes and free it up from the posterior structures, because when it gets tight and bind, you'll find that it's hard to actually lift away from the rest of the tissue. Cameron's is actually fantastic. It's the most mobile SEM I've.
I play with it all day.
Do you?
Why, yeah.
Is it okay? So you're a SEM player, okay? If I picked out half a dozen of you in here, there's no chance we could do this work. So okay, so we get from that picture that we can free up SCM just by a little bit of doing this work, okay, and that will give us better access to that Scalenes anterior. So when I access Scalenes anterior, we bring the head over, okay, so we're shortening, okay, relaxing that SCM, and then we're just sinking in again, not pushing, sinking in, okay, pushing SCM out of the way, and then basically we should feel a nice tight, well I'll say tight, but we should get the feedback of taut bands within that Scalenes. How's that in there?
Bit tender.
Bit tender. Just make sure that your fingernails have been trimmed, don't have any sharp edges on them. It's sensitive enough to work in this tissue without having razor sharp fingernails. How are we going here, Cam? Scale, pain scale?
That's alright actually. Not as tender as it was.
Okay.
About a 4.
About a 4. So when I engage it, so it's this lower portion that I'm more concerned with, because that's where most of the trigger point activity is. And I can just work backwards and forwards over that. You right there?
Mm-hmm.
Okay. So once again, working in any of these structures around here, areas of endangerment, we don't want to do too much work in this area. We want to get in, make an influence, and then get out. Okay. Okay. So that's anterior. Roll off anterior, and then we're on Scalenes medius. And similar situation, except we're just following the line of the muscle down to the, what does it attach onto? First rib. You all knew that, didn't you? So when you're assessing for Scalenes, especially if you're looking at thoracic outlet syndromes, it's always a fairly good rule of thumb just to try and locate the first rib on your clients. So the idea is that you get to the front of your traps, push your traps out of the way, and then basically push down onto that first rib there, okay? And if you're finding someone's a little bit higher on one side than the other, that may indicate that Scalene is actually quite tight on that side because it's lifting that first rib up. The neural anatomy for the neurovascular bunch that supply the arm is that we're obviously exiting out in between the anterior and the medius Scalenes muscle, correct? Coming down, we go underneath the clavicle, okay? Come across the anterior chest wall, and we come out to this anterior shoulder area where we've got our pec minor. So pec minor obviously overlies that neurovascular bunch, okay? And then they split up and they go all their separate ways to go and innervate the different muscles. So it's Scalenes and pec minor that we're most particular about in terms of neural impingement in this upper part of the shoulder and neck. Okay, so medius, stripping through there. It's good, feels good. Once again, just enough to elicit a change. We don't want to over-treat this area. And we're always guided by our clients' irritability. So how much feedback are we getting for the amount of resistance that we're putting in with our clients? So if they're really struggling, then it doesn't mean we go deeper, does it? Just back it off a fraction. Okay, so, and now we're into the posterior. So now I'm dragging the trapezius muscle out of the way and then locking down onto the posterior Scalenes. How's that feel there, Cameron?
Not too bad.
Not too bad. Once again, this is a very exquisite discomfort from Scalenes posterior. And I'm just incorporating some rotation as we work through that area there. Okay, good. Okay, so that's our Scalenes muscle. Now, Cameron come in and he had more thoracic outlet sort of syndromes, then we could probably move in and do some MET work, muscle energy technique onto that first rib. But given the nature of Cameron, he's all right. And I actually didn't perform any MET stuff on the client that I had, but I thought I'd just mention that. Now, pec minor. So before we get to pec minor, we need to get to what overlies pec minor? Pec major, correct? So what we'll do is we'll just quickly strip out a bit of pec major. I'll have to do some ballerina stuff here, table's a bit low. So let's pick up pec major here. I know this looks, I've got an adjustable table, electric table at night. Okay, so I'm picking up and just trying to fascially free up the lateral region of the pec major. And no, I'm not pushing into his trachea, and so it's at that lateral wall. How are we going there?
It's fine.
It's fine?
Mm-hmm.
Pain scale?
Fine.
Okay, so this is a sort of a more of a myofascial technique, myofascial tension technique, I should say. Lateral border again, can you see that? Is that better there? So it's all coming from here, okay? So I'm hooking under, lifting, and then engaging. So that's as far as I go. That's resistance that I'm getting there. And then I'm applying a tensional load, stretching load, and then you can use a little bit of shoulder abduction as you do that. And if they're loose enough under here, your fingers should bump straight into pec minor, which is right there, the edge of pec minor, which I do with Cam, and I'm going to lose your arm. I'm multitasking here. Don't say it, I know what you're going to say. Okay. All right, then stripping through pec major. So engage, there's the clavicle there. Roll off the clavicle. There's the subclavius deep to the clavicle. Engage and then dragging towards. We're right there. Yep. Okay. And we can go all the way out. Follow it, picking it up through the front of the shoulder. So that's still pec major there. Okay, we've got the anterior deltoid here, but pec major still comes all the way out here. Okay, there it is there still. Okay. Really important to free up this area here. Gets missed, or this is all the juicy stuff. You all right there, Cam?
Yeah, I'm fine.
Okay, all right, so that's pec major. Pec minor, run your fingers over it, flicks back and forward. It's not hard to find in terms of palpation-wise. Treatment to our pec minor is going to be coracoid process, and if we're looking at trigger points, then obviously there's going to be a trigger point just off the attachment. Sorry. So we're going to engage the digital engagement, and then just stripping through the rest of the muscle there. Sink, engage, and load. Take a deep breath. Take a deep breath. Cam. Make sure that your client breathes. Load load. And you can also, if you want to, just add a little bit of range of movement to this as well. So Cam, can I just get you to go up into a little bit of abduction? That's it, that's enough. And back down. So you only need a little bit there. Okay. All right, so that's pec minor. And you would usually see significant, if you're getting that neural impingement or compression onto that neurovascular bunch through there, then you should see a fairly good change reasonably quick. Okay, so that brings us to our other internal rotator, which is our subscapularis muscle, which not everyone enjoys, but pretty important muscle. Once again, use a reasonable amount of lube for this. Once again, delicate tissue, delicate area in here. So once again, pretty important. The fingernails are trimmed, and okay, that's good to go there now. All right. So location. We're looking at. There's the axilla area there. We're looking at that posterior axillary fold. So there's the lats. I can pick up the lats there. Okay. I go to the anterior border of the lats. Okay. And then I sink in until I feel, once again, resistance, which is about there. Okay, so we're not up in there, which is the axilla, we're down here. So make sure that you're always guiding the direction posteriorly. Okay. And then as we sink in, we hit resistance. And then to get in, unfortunately, I have to close this arm off and then let it relax, and then I can sink in a little bit further, and then I'm engaging subscap there. How's that feel there?
Tender.
Bit tender? Well, let's face it, subscap is usually tender regardless. It's just a matter of how sensitive it is. So now we can start to work engaging and just taking through some external rotation. Here we go there. All right. Okay. And now I want to do a little bit more sliding work, longitudinal glide. So I'm still engaged, and now I'm gliding through the lower portion of that subscap. So we've got two trigger points. We've got one up really high, up in this area here, and another one sort of midway down. And this can refer right to the top of the shoulder. Sometimes I've had people say that they feel like the top of their shoulder is going to pop off. The type of referral they get. Okay, so that's subscap. Once again, we don't want to be in there for too long. We've got pretty good external rotation anyway. Okay, that's good. All right. So we've cleared out those neck and shoulder areas, the areas of importance. Now we can move to our friends, the triceps. So we've got the medial head, and we also have the lateral head. In particular, the medial head, which is around this area here, has two trigger points up quite high. So can we have your hand there? Is that all right there like that, Cam? Yep. So triceps are coming down here. We can have a trigger point right here on the tricep attachment. We can have one here also on the medial head, and then another one on that lateral, that lateral head as well. We need to be careful of this medial head because we have what nerve running down here? That's the ulnar nerve. So don't be massaging the ulnar nerve. Well, you can, but it's not much fun. Not for your client anyway. We know what it's like when you hit your funny bone. So just, if you're getting, and sometimes you do get paresthesia, pins and needles. Oops, sorry, Cam. Now, how's that shoulder feeling, Cam?
It's fine.
You sure? and make sure that it's supported. Some people in that position there, if they've got a supraspinatus problem, then they may actually find that it'll overwhelm it. You seem to be all right. Okay, so it's a matter of stripping out the medial head and the lateral head, and it's important to assess whether or not there is a change. So I trial treat, which means I'll be doing a little bit of work through here, locating the trigger points, doing a series of, say, a minute's treatment on each of those, and then I would retest them for their symptoms. Okay, so we know that our signs and symptoms, our objective assessment, we were having pain on wrist extension. Just make a loose fist for us, Cam, okay, and pushing up against me, and that would elicit the elbow pain. Relax. He was obviously having tensional pain through the extensors as well. He was having pain on elbow extension, especially on the lockout phase, so as you're push down against me, and he was having pain on that as well. So they're the three, and also a grip test. So squeeze my hand hard as you can, and that would elicit. So they're the four main tests that we retest, okay?
Stuart, can you stop just for a second? Sorry.
Supraspinatus. Okay, so we're retesting these structures as we work through, and as I said, the triceps, medial head and lateral heads, in particular the trigger points in the lateral and also the medial, they refer into the elbow, and then obviously that tricep attachment as well. So I always put the elbow in a little bit of flexion and then palpate that tendon attachment, and once you find that trigger point, which is probably about 2 centimetres up from the attachment, and then you can just do some longitudinal gliding through that tendon itself. And the feedback could be very much like I feel an intense discomfort into the elbow. All right, so there we go. Right, so we've cleared our triceps out. Now we're looking for the Anconeus. So that little muscle that sits in the pocket of our elbow, okay? If you all palpate your Anconeus now, I'll be surprised if anyone doesn't have a little bit of pain in there. How's yours, Cam?
Not bad.
Yeah. Someone said ow. They've just found it. Okay, so stripping Anconeus, it's not a large muscle, so it's pretty reasonably easy to engage and then strip through like so. And in particular, I would retest this on our elbow extension. So just pushing down against me, build. How does that feel? Better, worse, the same? Okay. Now there's one condition that I didn't mention in the differential diagnosis, which I feel is fairly important for elbow pain, and that is your pronator teres syndrome, where you've got the pronator muscle, as opposed to the supinator muscle that can impinge on the nerves around the elbow. But your signs, your objective assessment would show that you would have come up with positive signs of resisted supination and pronation with that particular condition. Okay, so that's Anconeus, triceps. Now we're going for our supinator muscle. Now supinator obviously attaches out here, but to get access to it, we're going down through the brachialis, in between the brachialis and some of the other flexor groups. So I'm going to stand up for this one. Give the knees a bit of a break. Right there. So we're looking at, it's not unlike the case study that I did on leg when we were talking about tibialis posterior. You're going to be pushing supinator back onto one of the bones. This bone is obviously going to be the radius, and that's how we know we're on supinator itself. How does that feel?
Not too bad.
Now you may find that working supinator may also refer pain into the lateral elbow itself. Okay, so we're looking at trying to free up supinator if it's hypertonic. So it's got a considerable amount of hypertonicity through the muscle. Then it can squeeze on that radial nerve. Radial tunnel syndrome. Third most common peripheral nerve entrapment. A lot of people have never even heard of it. So very important muscle, supinator. And look, our brachioradialis, for any therapist or any person that works with their hands, obviously that's always going to be a muscle that's quite sensitive. You just pick it up yourself and give it a squeeze, and you'll find on a pincer grip there'll always be a considerable amount of sensitivity. So that's our benchmark. So we roll off that brachioradialis into that gully there, sink down, find that radius bone, and then strip through. Okay, up towards the elbow. All right, that's good. Okay, now flexors and extensors. I'm doing a lot of myofascial work through the flexors and extensors. He's got a reasonably hairy forearm. So we've discussed how to approach hair in terms of a myofascial point of view. If that's the case, I find a technique where you engage the tissue, like so. Okay, so I'm ready to go there. And then I drag it back towards me and re-engage again. And it tends to take a lot of the tension off the hair follicles. So this is going to be a reasonably slow process, and I do this in batches when I'm offloading the extensors. How are we going here, Cam?
Feels all right.
Feel all right?
Yeah.
Not too much?
No.
Good. And can you just wiggle your fingers for me, Cam? Just a little bit. That's it. That's good. So if you find that you're getting areas where it's quite stuck and you don't want to force through there, which you shouldn't, just get a little bit of movement. Usually that just means just get them to wiggle their fingers just a little bit, not like a lot, but just slightly wiggle their fingers. And that can sometimes speed up the process, I find. Look, and there's no doubt that if we work through the extensor carpa radialis brevis, which is the main muscle involved with lateral elbow pain from an extensor tendinopathy, that we will get some tenderness there as well. Now I'm just going to do a little bit more of a broader approach. Yeah, that's good. Now this is more so to try and free up that myofascial tension through the flexors. So when we were reassessing, okay, for the stretch through the extensors, how does that feel now, Cam? Better, worse, same? Where are we at with that? Okay, and if we're working the extensors, we need to work the flexors because they're the antagonist, if you like, to it. So we're also going to free up those as well. All right. And let's just add in some range movement there. How are we going there, Cam?
Yep, feels fine.
Feels all right? How many of you here have this sort of work done on you on a regular basis as therapists? Next. Do you think we should? How often do you think, if we were therapists treating each other, how often do you think we should have this work done? Once a week, yes, those definitely. I'm just as guilty of it as you guys, so I'm not here to preach. Now, if you find that you've got a client coming in and they have an inability to lie their hand flat out like that, and you tend to find that it's rolling in like this all the time, you may get those clients, I don't know if you do. Let's look at that pronator teres and just free that up. So that being the case and you're having trouble and you're always getting to there and it tends to feel like it wants to roll back in, put the arm in, or the forearm into this position so it's sort of relaxed, the flexors are relaxed as well. Come out to the pronator teres attachment is, and just strip through myofascially the length of this muscle. But you've got to do this really purposefully. Here we go on there, Cam, all right? And that usually should free up that pronator teres tightness. And I tend to find that it's just really just tensional, it's not adaptive shortness, where we're going to struggle to get a change in the immediate. Okay, so that's our pronator teres. All right, then now finally the treatment sequence will finish. I'll have done all that work. It'll finish with obviously the grip test. So it'll mean squeeze my hand, Cam. Wherever he feels that pain, that's where I work. All right. So if he says, no, I feel it up here, or I feel it here, or I feel it here, or wherever the case he feels it, that is where I treat. And I continue to treat like that for the last part of the treatment until we clean up what I call the subsidiary pain sites. Okay? Because as I've mentioned before doing these case studies, it's never just a single muscle syndrome. There will be other muscles involved, and some of those muscles that we're looking at are the synergist muscles. So when you get a muscle that's overloaded, obviously we switch on or we use other muscles, and those muscles then become overwhelmed quite quickly, which is what happens with our rotator cuff, because our rotator cuff muscles are only small intrinsic muscles. They do small intrinsic pieces of movement. And then we have our larger big prime movers like our deltoids and lats and all these other muscles. So when they fail and don't work, the rotator cuff muscles become what? They become overwhelmed really quickly. Okay, so it's the same scenario with this situation. Same with the hip when we're talking about the glutes. TFL becomes overwhelmed really quickly. Okay, the unfortunate thing about that is that it doesn't function in that process very well. All right, so that makes up the treatment for that area. The one area that I've just realised that I've missed, which I wouldn't do in treatment, I would never miss an area, and that is our supraspinatus and our infraspinatus. So what we might do is we might just spin you over onto your front and we'll clear that out too. For any of you who have seen the DVD I did on the shoulder, treatment of soft tissue function on the shoulder. Part of the process of clearing out the shoulder is freeing up the lower portion of the trap fibres from that latissimus dorsi. So I'm assuming that when I'm treating this area, I've freed those fibres up from each other. Primarily because if we've got internal rotation of that shoulder, that trap is going to be held in the lengthened position, and then like any muscle that's held in a lengthened position, it'll tend to bind down to the tissue beneath it. Okay, so we need to free that trap up from that lats. Okay, so just given that I've done that, and we're moving on to the rotator cuff muscles. Supraspinatus, infraspinatus, they come here together and they join. Supraspinatus is sort of anterolateral, and then obviously we've got a little bit of a posterior attachment for the infraspinatus, very close to each other. You know, if you look at that cuff, there's not much between the attachment sites. It can be really confusing, people coming, oh, I've got infraspinatus tendinopathies. How can we see that? Is that all right? Okay, so we need to drag traps up and out of the way. okay, that anterior border, and then once again we're sinking down into the traps, all right? So I'm lifting the traps there, lifting it and sinking in so that I'm right onto that supraspinatus. So I'm pushing supraspinatus into the supraspinatus fossa. Okay, and onto the knees again, sorry. You can see there, you're right. Okay, so I'm always working towards the attachment for supraspinatus. Can anyone hazard a guess why I would do that? Well, it's to do with blood flow, okay? Because blood flow to our supraspinatus is reasonably poor compared to some of our other muscles, and so we're always trying to bring blood flow to the actual tendon itself. Tendons need blood, especially ones that are not happy, okay? So stripping through that towards, usually we'll have a trigger point in the mid portion and then also that trigger point just before it delves into that subacromial space. Okay, put it in just a slightly more lengthened position now and then strip to that lower portion of it, just before it dips away underneath into that subacromial. I've mentioned dry needling. Dry needling is great for supraspinatus, but always important that if you are needling, that you get the direction of the needle right, because you don't want to be needling into the lung, punch the lung. Okay, so that's our supraspinatus. Also, we want to have attachment treatment as well. So we do resisted tests again. Where are you feeling it now, Cam? Yep, right there. So we're going to work that attachment site, but we'll do that when he's turned over. And then obviously infraspinatus, trigger points for infraspinatus just below the spine of the scap. There's our spine of the scap. So we'll engage mid portion of it, sorry, the medial portion, and I'll roll off the spine of the scap and then engage and strip out those trigger points. Okay. Like so. How are we going for time? 10 seconds? 2. Okay, so we're stripping through there, infraspinatus. While we're here, we may as well work the teres muscle, which is going to be more on the lateral surface. So pick up the edge of our scap, and there is that exquisite silver dollar pain of teres. How are we going here, Cam? Usually you'll get a reasonable twitch response with teres. Better. Not the most ergonomical way to work, but okay. And with any of these muscles, I don't necessarily just work them in the static position, pop them up a little bit further, work through here as well. Good, and then Cam, spin onto that side for me. That's it, beautiful. You're right there.
Yeah.
1 minute. You're all probably familiar with this technique. It's just another way to work out supraspinatus, infraspinatus attachments. So coming in through this way. So once again, this is a really good way to treat supraspinatus and the infra. Provided they're not having too much pain and discomfort at the end of the range. Okay, so make sure that you... Okay, just push up against me, other way. Okay, how's that feel? Any pain? Better, worse, same, whatever the case may be. Whereabouts do you feel it? So this is usually a really good opportunity to work those areas there. And Done.
So, for everyone, thank you very much for coming for the weekend. I think it's been a real success. It's been great. So, many thanks for coming along. And in the future, we're planning on doing some other case study work. So hopefully we'll have you along again, where we have an opportunity to hear about some of the real life experiences that Stuart comes across in clinic.
Yep.
And the ways that he can work with them and hopefully impart some knowledge onto you guys. So thank you all very much for coming.
Also, can I just say something?
Yeah.
Can I really enjoy the feedback that we get from these, because this is the first time we've done the case study series. Obviously, we want to try and make it more interactive. If you have any ideas or things that you thought that we may have missed out on or you think that could improve it, we'd certainly love to hear it. I'm reasonably passionate about this type of presentation because it gives you the real life flavour of when you're out there treating and more so, like I said at the very start, the decision making process that you go through. What should I treat? When should I treat it? How do I treat it? And what are my outcomes? And I think it's really difficult out there as therapists because you basically close the door and you're in there with your clients and that's it. There's not much interaction apart from you and your clientele. So when you come to one of these things, obviously you want to try and learn as much information as you can that you can then utilise in there as well. I don't perceive to know it all either as well. I'm here struggling and fumbling through the clinical experience just like you guys. But if you can set yourself limitations and knowing what you're good at and what you and the outcomes you get for your clients, you're obviously doing the best that you can. But at the end of the day, these resources are meant to try and just help you be better therapists, and it makes me a better therapist doing these things as well. And I feel really passionate about this area. And when I approached Dave about this and doing this, I think it's an area where we sort of lack a little bit, especially because there's not much mentoring in our industry. So you come and do your undergraduate studies and then we ship you off out into the big wonderful world of clinical, and then you're sort of like lost for 5 years going, oh, what do I do here? Who do I refer to? And just getting to know the pathologies that you work on as well. And you can come to these sort of these seminars and actually rehash what you've learned and then go, yeah, okay, now I think I'm on the right track, or yeah, no, I didn't realise I could do that, or if you take one thing away from these workshops or these seminars, then obviously you've got your money's worth as far as I'm concerned. So, yeah, but we'd really appreciate any feedback you have, constructive, whatever form, shape it comes in is always good. So thank you very much for being.